All right, thanks for having me, everybody. I'm really excited to talk today. I'm excited I got to see all the other talks today. I'm going to make it a little bit of a challenge to weave in something that every other speaker talked about today, not only because I think that'd be interesting, but I think that fits very well with the talk that I'm going to be giving today. But I first want to give a little insight into what neuropsychology is. Some people I know in the audience I've seen for evaluations. Other people probably have no idea what it is. Neuropsychology is just our best way of getting a good sense of how somebody's brain is working from a memory standpoint, attention, language. And if you've gone through an evaluation, you see that we try to do that mostly in really practical ways. If we want to test your memory, we ask you to memorize some things, and then we see how you do relative to other people of your same age. That's important for every test that we give. It's what is average for a 35-year-old? How should you be performing on this test? And then if you have some challenges and in a pattern that fits with MS, then we might say, okay, well then this weakness looks like it might be directly related to MS. Being a neuropsychologist, obviously the psychologist is still a big part of that, which I think is really nice because mood has really been represented nicely today, and I think in a lot of different ways. So Diana obviously spoke a lot about depression and anxiety, but also about how people cope and how people adjust. And I really like this idea that sometimes the response to MS can be just as difficult to work through as the condition itself, especially early on. And Felicia really mentioned nicely as well about this idea of listening to your body. I can only imagine early on, it can be a little difficult to listen to your body, especially when you don't totally trust it anymore and don't know what certain cues mean, what certain cues don't mean. So what Diana was talking about, one response is obviously avoidance. For people who don't even want to think about the condition, they want to even avoid taking medications. You can think about the other end of the spectrum being kind of over-focus, kind of a hyper-focus on the condition and your body in particular, which I can hear from people a lot of the times, is that all of a sudden you don't really know what represents normal or abnormal anymore, which can be really hard. Obviously, someone without MS, maybe in their 30s, who wakes up with their leg asleep, immediately they're thinking, oh, I slept on it funny. Whereas for MS, it might take a couple minutes to figure out if that's the case or not. So obviously, while avoidance is a problematic coping style, being a little too focused on every sensation in your body, every memory slip you have, can also be problematic because everybody has those to some degree. So hopefully with the presentations, all of them today, it's a matter of hopefully centering and normalizing things to some degree. And that's really what I hope to have people take away from this talk is, okay, this would probably be related to MS. Some of these other things might not be so related, and a lot of people just experience those in general. And I think that dovetails nicely to this first slide. So in thinking about cognitive difficulties in MS, as you see from the first bullet point, a lot of people experience them. Kind of comes up over and over that about 50% of people with MS will experience some level of cognitive dysfunction. And there's a couple really important points to that. The first being is that there's such a wide range of what cognitive difficulties can mean. There can be impairment, where obviously with something like Alzheimer's disease, their memory is gone. That's definitely an impairment. Or it can just be a really subtle issue, as in, oh, I can still do something, but it's a little harder than it used to be. Calculating the tip on a bill is just a little harder, but I can still do it. It just takes me a couple seconds longer. That spectrum is so wide, and that's really what I and other neuropsychologists try to account for with our testing is, oh, okay, you felt like your memory was gone. Well, actually, it's not gone. It's just here are some of the troubles you're having, and how can we describe that? The other really big thing about cognitive difficulties is that people really don't have a good sense of how to judge their memory. I think we're always thinking about maybe how we think to some degree. Everybody jokes there's kind of the member of their family who maybe doesn't remember things that well. But for the most part, it's really hard to know how well we're doing from a cognitive standpoint. And in fact, there's a couple really nice things that come out of social psychology that tell us about this. One of which especially is prominent for people who are diagnosed with neurological conditions, MS being one of them, is something that's called the good old days bias. A lot of people tend to think before you have a diagnosis of something, prior to that, you were the best. You were a straight A student, you're the best looking person in your class, homecoming king. And then after the condition, all that's changed. It's like, okay, well now I'm a C student, now I'm not so good looking, and now I probably wouldn't even be on the homecoming court. But actually, that's just a bias that we all have, that sometimes after you have a diagnosis, the response to that is to think, I've changed so drastically. when maybe that change is pretty subtle, and maybe you're comparing yourself to somebody who never really existed. So yeah, that person who was an A student, maybe you were actually a B student when we look at your records, and maybe actually you weren't really homecoming king, you got a couple votes and were on the court. So that's just really important to acknowledge that it's really hard to know what you were before versus after, and that's where having some objective testing can be really useful. So in terms of talking about cognitive difficulties with MS, it's really helpful to break it down into primary problems, primary causes of cognitive dysfunction, and then secondary causes, which I think a lot of people have spoken about really nicely today. So as you see, one of the highest risk factors for causing cognitive problems with MS is the type that you have, as been kind of talked about a couple times today. And unfortunately, the most problematic course is progressive. And whether it's primary progressive or secondary progressive, people with that condition are more likely to have cognitive problems. And very likely related to that is duration. The longer that you have MS, the more likely you are to have cognitive problems, although that probably relates to the fact that people with relapsing remitting transition to secondary progressive a lot of times, which Kelly had mentioned really nicely, and I'm really going to bring that back later as well. Neuroimaging is something that I know I look at a lot in the chart. I see a lot of the MS folks talk about this as well, is that when people get their MRIs and they see comments about lesions, it can be really easy sometimes to try to figure out where one of those lesions are and see how that correlates to the type of problems you're having. But really it comes down to how many lesions, what is the burden of lesions on your brain. So a lot of times you'll read MRIs for people with MS, and it'll say mild lesion burden, moderate, severe. That tends to be a better correlator of cognitive dysfunction than like in a specific region, for instance. So if you ever read in one of your brain MRIs, look to see if they comment on the level of disease burden, and naturally mild, moderate, severe, those would all tend to correlate more highly with cognitive problems. And then finally, unfortunately, men tend to be more likely to have cognitive problems than women in regards to multiple sclerosis. And I haven't been able to find really, Dr. Baggert might know better than me for this, why that's the case. The only thing that I had found recently that made sense to me and I think relates to a lot of other things I talked about is that early on, younger folks who are diagnosed with MS, women generally are more likely to be diagnosed, but early on, men and women are one-to-one likely to be diagnosed with a progressive MS in like their 30s. So what I suspect happens in studies is that there are a lot of women who have relapse and remitting, and there are also people with progressive in that study, whereas a lot of men might be progressive. So I think it's probably more indicative of the type of MS you have. It seems like maybe males are more likely to have a progressive. Okay, so now it's helpful to talk a little bit about what type of cognitive problems you have in MS. Some of these I get from reading about it. I think a lot of hopefully helpful things I've gotten from patients. But when you start to Google things, like what are the most common types of cognitive problems with MS, you even see this in the books, it basically lists every area of cognition, which is incredibly not helpful. So what I've tried to do is break it down to what's most relevant. And I think what's most relevant is not only what we know about the condition, but what I hear from patients a lot. And really the top one is processing speed. And it's a little bit hard to understand what that is. It even is hard for me to conceptualize until I hear about it over and over. But as has been talked about with MS, MS impacts myelin in the brain. And myelin is something that helps your brain move quickly. It helps move signals, impulses quickly through your brain. So as you can imagine, if you have less of that, then maybe your brain is more likely to move a little more slowly, and maybe a thought comes out a little more slowly. Maybe a word comes out a little more slowly. Processing speed weaknesses are consistently found with people with MS, but I also find that even when people do really well on neuropsychological testing, patients are still complaining of, yeah, but something just doesn't feel quite right. Things don't feel as automatic. Things just aren't easy as they used to be. And I've definitely taken that into consideration more and more because obviously when I have really strong testing, I'll say, well, things look pretty good. But what I think for the most part people are just recognizing is that they can still do things, but there's some disconnect there. Something isn't just clicking as fast as it used to. And especially early on in the condition, it's great that it might not reach the point where anyone's having problems day to day. They're still working just fine. Maybe they have to spend 10 extra minutes at work. And no one notices that early on. That's totally fine. But if you had to add 10 minutes, maybe once a year, every year, Then maybe after about 6 years, you're adding an hour onto your work schedule. And it's like, okay, things have then eventually reached a problematic point. So processing speed, I think, afflicts people very early on, and they notice it even if it's not causing a big problem yet. Visual spatial abilities would really not be surprising. I think a lot of people know that visual changes are a big part of MS. So on our testing, we noticed it as well, that sometimes it can be an issue with depth perception, such as, well, maybe I miss one step when going up and down, or maybe I knock into the doorway when I'm walking through. Subtle or big things that people notice, but it constantly comes up on testing. I really like to talk about memory in multiple sclerosis because a lot of people know what memory looks like with Alzheimer's disease, but it very rarely looks like that in MS. People with MS can have difficulties on testing, but it really doesn't look like that. And really, it's a matter of how much information you're getting in to begin with. So one of the primary complaints when someone's telling me my memory is really impaired is they'll say, I can't remember people's names. That's really common, but that also really has too much to do with memory. If I introduced myself to you and only said my name one time, if you weren't paying attention or really never made an attempt to remember it, that's not memory because you never really had an opportunity to remember it. That's attention and coding. And those difficulties can be more pronounced in MS. And what we find, a common test that we give is a word learning test. So we'll give a list of 16 words once, twice, 3 times, 4 times, 5 times to see how much you can remember. What we find with the MS population is they're eventually able to remember as much as most people, but sometimes they need it 6 or 7 times. So it's not this matter of, oh, you can't remember all of a sudden. It's maybe you need more repetitions to remember. Or maybe you should just try to remember less than you used to. Obviously, if you're going to go to the grocery store, in the past, you probably could remember picking up those 6 things. Now, if it moves beyond 3 or 4 things, maybe you need to write it down. So don't think of memory with MS as the type of problem with Alzheimer's disease. Think of it more as, well, maybe I need to focus on remembering less than I used to, and maybe I need to rely a little more heavily on repetition than I used to. Those are the best ways to think about it. And if you ever Google anything about MS and cognition, or a lot of different neurological conditions, executive functioning is something that pops up over and over. And it's really this complex term that I think is really hard to understand in isolation. So really, you want to break it down. There's a lot of different abilities that go into executive functioning, but I think the most relevant for our purposes today, and what I hear a lot, is something that's called working memory. And it's the idea, working memory is really your ability to hold things in your head and kind of manipulate them. So for example, if I gave you a math problem like Susie went to the store with $19, she left with $6, how much money did she spend at the store? You're holding obviously a couple pieces of information in your head, and then you have to utilize that to come to a solution. That's working memory. Unfortunately, what you find with working memory is that people start to just gradually decline from that standpoint in their mid-30s, just normally, which is bad news. But with MS, you can see it get worse a little quicker. And I use that idea of, fortunately we don't have to use mental math a lot, so I use that idea of calculating tip at a restaurant, because really there aren't a ton of opportunities to do something like that. So beyond something like mental math, think of other things where you're trying to navigate multiple things at once. I think of cooking a complex meal, especially around the holidays, especially if things are getting done at different times. Something's boiling, something is in the stove, you're cutting something over here, you got little kids over, you got to leave the kitchen to go address them. That's holding multiple things in your head at once and tracking them, and also tracking the time for them at the same time. That's really complicated. And one of the things early on I'll ask people about is cooking. And if they don't cook, that's fine. If they do cook complex meals, then we got to figure out some strategies to make it a little easier. Maybe it's more worthwhile to stay in the kitchen when you're cooking and have someone else worry about the kids in the other room. Maybe you have to set alarms or timers. Maybe you focus on cooking one thing at a time instead of focusing on cooking multiple things. But that's working memory, that's cognitive organization. Those are difficult cognitive abilities that can obviously get worse with MS. So we talked about those primary factors that have to do with the disease. Some things obviously you can't control. You obviously can't control your chromosomes and being a man or a woman. You can't control what is going to be the condition that you're going to be diagnosed with, relapse, remitting, or progressive early on. But some of these secondary causes are things you can control, which is really nice. And I think that's actually what a lot of the talks today have really focused on. And what I always try to focus on with patients is, here are some things that we really can't control. Let's put all our effort towards things that we can control. And a lot of these causes fall under that umbrella. So sleep disruption has been mentioned a couple times. Diana mentioned it, I know, in her talk. And unfortunately, that you see, sleep can be a bigger problem in MS than the general population. I treat sleep as a symptom no matter what condition I see, because it is one of those things that you can improve to some degree. Maybe it's a problem with sleep hygiene, which is maybe you have a TV in your bedroom, or maybe you look at your phone all the way until you fall asleep and are keeping it right against your face, or maybe you drink caffeine late at night. There are all these things that we can try to consider that, all right, maybe your sleep isn't optimal because of things that you're doing. Maybe you have a couple drinks before you go to bed. We know that impacts sleep as well. So those are all things that are really secondary to MS, but if you treat it, you might feel a little better, especially from a cognitive standpoint. Everybody knows when you feel tired, you don't feel as sharp. That's the case with everybody. So if we know that people with MS are more likely to have cognitive problems, let's try to resolve one of those issues that can make those cognitive problems even more pronounced. Naturally, fatigue, chronic pain, those are all things that help you just not feel as sharp either. What we find in the literature is that chronic pain doesn't necessarily make you do worse on testing. It doesn't make your memory worse, but it can be distracting. I think we all know that to some degree. I've been standing a lot today, so my back hurts a little bit. And if I really focused on that, or if I was at work, every couple minutes I might think about that, and that takes my attention away. And that's just really important to think about, is trying to break down all the different things that can contribute to, oh, why am I so distracted? Oh, it's because I'm in pain quite a bit. It doesn't mean my attention is gone or my memory is gone. I should tell the MS team about my pain. Or my fatigue has been really bad lately. My sleep has been really off. I need to talk to my treatment team about that. Because cognition, once you kind of lose it to some degree, it's hard to get back. So maybe some of these things are the reason that it's causing problems and you actually haven't lost it, and we could treat these. I'll go back again to Diana and talking about mood, depression, anxiety, all of those things can impact how you're feeling to some degree. And actually a word that's been used a lot, Dr. Baggert used it a lot in her talk today, is this idea of disability being an outcome measure. And the way that I think about it a lot is functioning being an outcome measure, is that maybe there are some things about MS you can't control, but how are you functioning day to day? Like, are you still working? Are you still getting out of the house? Are you still able to do yard work? All of those things really matter just as much as kind of what your MRI shows to some degree. So a lot of our efforts, and hopefully a lot of the efforts and takeaways from today, is we're trying to optimize everybody's functioning to some degree. And mood is naturally one of those things that does not help people's functioning whatsoever. And in talking about depression, I really like this one study that looked at, obviously it's not great news that about half of people with MS can have a depressive episode in their life. But what we find is that in this one study, that friend-based support accounted for about half of those people who are depressed. And obviously family-based support is really important as well. For people who don't feel like they have a good sense of family support, they're more likely to be depressed. But this friend-based support is so important because I think it not only goes to friends, but probably just social support in general. So coming to a talk like today, this helps build support. It helps build networks. Going to the early diagnosis support group, having gone to that myself, to me that's clearly something that builds networks and relationships. So make sure that you're just relying on a lot of different people along the course of your condition, because it matters for mood. And as we've talked about already, mood matters for your condition. And I'll highlight that even a little more a little later. So in terms of prognosis, I actually think this is a really helpful slide. So I mentioned earlier that about 50% of people will experience cognitive dysfunction at some point over the course of their illness. What you find from a prognosis standpoint is that most people stay stable at least over a 3 to 4 year period. That's pretty good. However, patients who have impairment at the beginning of that 3 to 4 year period are more likely to decline over that time. And that isn't too surprising. What that probably has to do with is that probably suggests those people have progressive MS and that they're more likely to have worsening symptoms over that time course. Something that really clicked with me with Kelly's talk is this last point, is this longitudinal study had 50% of patients who did really well on cognitive function at baseline. Half of them at the end of a 10-year period were still doing totally fine, which is great news. So if you don't have any cognitive dysfunction at this point in the disease state, odds are pretty good that you probably can maintain that level of cognition 10 years later. But what stuck out to me from Kelly's talk is that the exact number she used is that about 50% of people from relapsing and remitting over a 10-year span are going to transition to secondary progressive. And I think that's probably what that last point gets to, is that if you're staying in relapsing and remitting, you're probably less likely to have cognitive problems than if you actually made the transition to secondary progressive. So Dr. Baggert specifically asked me to talk about brain health today, which I really like to do. And I think you're going to find a lot of, this is exactly the slide where I'm going to piggyback off a lot of other people. Everybody has talked about physical activity today, and it's not really a shock to me, and hopefully it's not a shock to you at this point. But obviously, not only is it good from a body standpoint, a heart standpoint, but it's really good for your brain as well. And there's a lot of literature where physical activity is pretty much the best possible thing you can do. And I really tend to go back to what Dr. Baggert had talked about with those vascular risk factors, is that the lower you can reduce your risk for heart disease, the more likely it is you're going to lower your risk for dementia. We know things like high blood pressure, high cholesterol, poorly controlled diabetes, all of those contribute to risk factors for dementia. So if we can control all of those, and exercise is obviously one mechanism for that, then that's obviously going to be the top recommendation. I did see 2 recent studies that looked at physical activity and risk for cognitive decline, and they didn't find many positive results. And their kind of conclusion was, well, maybe exercise is not going to be the panacea. It's not going to be the one treatment that cures all. I think that's pretty obvious. I think everyone knows that one thing isn't going to cure everything. So that's why there are multiple recommendations here, and that's why it's a lifestyle that really is the recommendation. And Dr. Baggert, and you'll see I talk about this a little later with diet as well, it's really hard to measure something like diet, for instance, that I could tell this half of the room, let's do a study where you just eat 10 raspberries, and this side of the room doesn't eat 10 raspberries, and let's see if 10 raspberries actually helps. We're not going to find anything helpful for that because everybody's diet is so different. So it's really hard to study lifestyle in general. So we really just try to put a lot of pieces together to figure out what can be the most helpful. And obviously, physical activity, a heart-healthy diet are going to be some of those things. But what's also really nice is that social and leisure activities, which I think a lot more people do in Louisiana and the New Orleans area, more than other places I've lived, where you'll go out and see a concert, you'll go to an art exhibit, you'll see a show. All of those things are really cognitively stimulating. I think most people think it's pretty intuitive that if you're doing a crossword puzzle, oh, that's really me using my brain. That's mental activity. But going out to eat with friends and staying engaged in a conversation, figuring out the next thing you want to say, filtering out all the distractions around you, that's also really mentally stimulating. Or going to a concert and listening to music, that's also mentally stimulating. So we find that people who don't live sedentary lifestyles, who are getting out, not only do better from a brain health standpoint, but you're obviously going to be in a better mood. And that really dovetails nicely into brain games. And then I think a lot of people, they think, okay, it has to be a crossword puzzle, even though I hate doing it. It has to be Sudoku, even though I'd hate doing it. There's not a lot of research at this point that suggests doing those brain games are going to significantly improve your cognition. And in fact, the data seems pretty overwhelming, is that it's not going to improve your daily functioning at all. When you play a lot of brain games online, and there are obviously a lot of people who are selling them, is that you really get better at one thing, and that's the brain games. You don't get better at much beyond that. So I don't know much usefulness for getting good at a brain game, but there is utility of trying to learn a second language or trying to learn how to use a certain instrument. There's definitely some things that you'll feel good about too, and those are just as, if not more, cognitively stimulating than playing a brain game online. And I just gave a little plug for a blog I wrote about it a couple weeks ago. But really, you'll be sold on a lot of things that can be miracles for improving cognition or reversing cognitive decline. As it has to do with brain games, I wouldn't rely on those much. Instead, lifestyle, physical activity, social activity are going to be more important. Avoiding smoking, I think, should be pretty obvious for MS, but it's especially obvious for brain health too. Anything that's going to be bad for your lungs is then going to impact the amount of oxygen that gets to your brain too, which is not a good thing, as you can imagine. There is an interesting anecdote about smoking that's worth telling, is that there is something people are wondering is maybe neuroprotective about nicotine, meaning is there something in nicotine that helps reduce your risk of certain neurological conditions later? And this came out of people had found that people who smoke are less likely to get Parkinson's disease, which is kind of interesting. But obviously the problem with smoking is that it can kill you in a lot of other ways. So this is not a PSA for you should start smoking. This is just an interesting anecdote that maybe there's something neuroprotective about nicotine that we'll find, but nothing really hard and fast now. And basically don't smoke though. There's this really nice idea called cognitive reserve that has kind of been proved a lot over and over in the literature at this point. And what this idea came from is that there was a big nun study where they looked at nuns' brains. And nuns are a pretty good population to study because they have pretty healthy lifestyles overall, so there are some similarities that you don't have with a regular population. And what they found is that there were some nuns who had significant Alzheimer's disease in their brain, but they were totally functional in daily life. They didn't even have memory problems. And there were some nuns who had just a little bit of Alzheimer's disease in their brain, and they basically had no memory. They were totally impaired. They showed all the clinical symptoms of Alzheimer's disease. And basically that was left researchers to figure out what gives. If Alzheimer's disease has to do, the amount in your brain has to do with symptoms, why aren't we seeing that match up? And what a lot of research has shown is there's this idea of cognitive reserve. And it's not too surprising that basically the more you have to lose, the longer it will take to lose it. So people who have a higher level of education, people who do cognitively stimulating tasks, have cognitively stimulating jobs, if you're using your brain a lot, that basically builds a lot of new networks. And the best way I can think about it is like a highway system. Obviously, and this is kind of the case in New Orleans, there aren't a lot of different ways to get around places, so when one street breaks down, you're in a bad spot. That can be the same way with your brain if you don't use it a lot. If you start to have some cognitive problems and one network shuts down, then all of a sudden you're demonstrating those problems, your memory is gone. But if you've done a lot of cognitively stimulating activities in your life, like being just a lifelong learner, learning a second language after school, or learn how to use a musical instrument, all of a sudden your brain starts to develop new networks. And when you have new networks, you have more to lose then. So for someone who doesn't do much learning, they might have 5 networks. Someone who does a lot of learning might have 10. So they both might have a similar degree of MS. And when they lose those 5 networks, this person over here is going to be really impaired. Whereas this person over here might have difficulties, but they're still functional because other parts of their brain are able to compensate for that. So I think that obviously to some degree it's hard to build up cognitive reserve in your 50s and 60s, but being a lifelong learner can only help you for those who are younger. But also if you are middle-aged, it is important to keep learning. It's only going to help, and especially learning things that are going to be practical that make you happy. Learn how to do a crossword puzzle. If you hate it, it's probably not going to make you happy. The only last thing I would talk about diet is because it's come up a couple times today is coconut oil. That's come up a lot in Alzheimer's research and in terms of keeping your brain healthy in general. And as Dr. Baggert talked about, that there are some cases that are just anecdotal. They're kind of one-offs. And that's really much the same way with coconut oil, is there's really not much evidence to support it. It kind of came from one group in Florida, and they really haven't been able to replicate or show much benefit of it since. And also, coconut oil is pretty high in fat, so if it's something that you're really convinced you want to do, talk to your doctor about it first. So to wrap up, in terms of what you can do, how to treat the primary causes of cognitive dysfunction in MS is taking your medication, is following the treatment plan. Because obviously, as we've talked about today, if it can help alter the course or slow down the progression, then it's likely going to change the progression of cognitive symptoms you have as well. But you really have to treat and manage those secondary causes: pain, fatigue, sleep problems, mood, because not only will those cause issues in your daily life, but maybe they alter your ability to follow along with treatments. I've heard it so many times that it's not that people forget to do certain medications, it's that at some point, the third Copaxone injection at the end of the week you just don't want to do. And that becomes exhausting, and it's ruining your day, and you just don't want to do it anymore. I think we all appreciate that to some degree. In fact, I was just talking to someone about it yesterday, that it's really easy to think that, 3 days a week isn't a lot. But if you have to, I have something I have to do once a month that I don't like doing, and every time it comes up, I'm like, it's been a month already? That's unbelievable. So if you have something you don't like doing, 3 times a week sounds like so much. So it's really something to talk about with your doctors, acknowledge it. If it's getting you really depressed on those days, Figure out different ways to manage your mood on those days. Finally, optimizing brain health, your vascular risk factors. And then finally, if you're noticing some cognitive difficulties and them getting in the way of your life, how do we compensate for those? As I mentioned with cooking. So maybe you set alarms, timers. If you are forgetting medications, setting alarms on your phone, using a pill box, things like that.